Good evening. My name is Dr. Bunkis of Orange County Plastic Surgery in Newport Beach, California, and Salisbury Plastic Surgery in Worcester, Massachusetts. First of all, I'd like to thank you for joining us for our virtual Rhinoplasty Seminar. We're going to cover both the aesthetic parts of a rhinoplasty as well as the functional parts. This is one of the more common operations that we do at Orange County Plastic Surgery and Salisbury Plastic Surgery. And interestingly, last week the American Society of Plastic Surgeons put out their consensus numbers for last year, and rhinoplasty was right at the very top of the list as the most common plastic surgical procedure performed in the United States in 2020. On your left, you can see our office staff at Salisbury Plastic Surgery in Worcester, Massachusetts. Directly to my right is my associate, Dr. Deborah Ekstrom. On the photograph on your right, you see my office staff at Orange County Plastic Surgery in Newport Beach, California. I say luckiest man in the world because these folks will make your patient experience wonderful, and they're so delightful for me to work with. Nasal surgery can be purely aesthetic, functional, or as frequently happens, a combination of both. I will try to go over the various aspects of such surgery to give you a better understanding of your options in this webinar. Airway obstruction implies anything that prevents air from reaching your lungs. In trauma, for example, a tongue or collapsed jaw frequently leads to airway obstruction. With regards to rhinoplasty, the causes are usually a deviated septum, enlarged inferior turbinates, or a lateral wall that does not provide support for your airway. If a patient's nasal rim collapses when they are trying to inhale, they have lateral wall collapse. This can be helped by inserting cartilage grafts in the nose, or a simpler method is by insertion of these Lateral absorbable implants into the nose. This can be done at an office procedure. The following video shows you how these implants are inserted. Today we're putting in a Lateral implant in this young lady. She has a relatively narrow nose, and when she inhales, you can see this part collapse, and she's not getting air in. And the Lateral implant is made of the same stuff that Sculptor is made from. This is basically where we're going to have it sit, and I'll show you how we load it. This is what comes in the kit with the Lateral graft. The implants themselves are very, very tiny. They're absorbable. They last about 2 years, then they absorb. I don't know if you can see that, but that's what the implants look like. To load them, we put them inside this little gun, close it up, and it's ready to go. You have to make sure that the top of it sits on top of the bone. And as I go through, I can feel it with my finger. You go on top of the bone, and I can feel where I am at the end, right where I want to be. You fire the trigger, and you remove it, and that's done. When I was a resident at Harvard University in the 1970s, cadavers were plentiful, and we can do dissections such as these to learn nasal anatomy. Rhinoplasty is one of the most difficult procedures to teach someone because in those days we used very tiny incisions inside the nose. Since cadavers have become less plentiful, an open approach has become more popular, in which an incision is made at the base of the nose and the entire skin is flipped up. These open procedures are easier to teach the rhinoplasty procedure to a resident, but in spite of that, most residency programs have an inadequate exposure to rhinoplasties for the residents. Rhinoplasty surgery leads to dissatisfaction because too much was done, crookedness or irregularities persist, or breathing problems either persist or develop after the rhinoplasty procedure. Rhinoplasties are definitely one procedure that not every plastic or ENT surgeon should do. Please do some homework and make sure that the surgeon you are considering has ample experience doing rhinoplasty surgery. This is an example of a patient that came to me after 2 open rhinoplasties which were severely overdone. She has a pinched tip, has difficulty breathing, and has an over-projecting tip. This is very difficult to correct. I am sure that the doctor who did the previous case thought that the patient looked fine, but our goal as rhinoplasty surgeons is to meet the patient's expectations, and a part of that is to match the patient's facial features. Some patients are not aware that they have an issue like a weak chin, which definitely detracts from the appearance of a great profile after doing a rhinoplasty. My anesthesiologist, while I was working in Northern California, came to me and asked if I can remove some excess skin from his upper eyelids and to straighten his nose. He had no concept that his chin was weak. If you look at these pictures from the front, you can see that his nose is straighter, but he still looks like the same human being. One thing that many patients are afraid of is looking different after their rhinoplasty. As you can see from his front views, he looks like the same person with a slightly straighter nose. But on the side view, his profile is dramatically improved, not only by removing the small dorsal hump and placing a small graft at the base of his nose, but by adding a chin implant and suctioning the neck. If this person would not have wanted me to put in a chin implant, he would not have gotten anywhere near this satisfying a final result. This is an example of an attractive 27-year-old nurse who did not like her full nasal tip and small dorsal hump. You can see from the front view that she still very much looks like the same person, perhaps a little refined. The improvement is a little more noticeable on the side view. You can see that her tip is not as bulbous and that the high point of her nose is the tip and not some point over the center of her nose. In most of these cases, what you will notice is that we are trying to make the very tip of the nose higher than the nasal bridge. I used this lady's photograph in an earlier blog last week. This is an example of someone who needs very little done to their nose. We do not like to do minimal tummy tucks or minimal breast reductions because of the visible scars. But in a rhinoplasty, a minor improvement is feasible if that is what the patient wishes, because there are no visible external scars when done by the closed technique. Her concerns were twofold. First, her nasal tip was a little bulbous, and she had a very minor nasal hump. Both of these issues were corrected in a 30-minute closed procedure with this pleasing final result. This is another patient who was 18 years old and did not have anything very major wrong with her nose. She was finishing high school and wished to go to college with a refined nasal look. What bothered her was she felt that her nose was too long, the tip was too bulbous, and she disliked her minor nasal hump. On the side view, when smiling, the nasal tip will plunge if the nose is too long. As you can see in her photographs afterwards, her tip stays elevated. This was accomplished by working on the tip and by placing a small graft over the base of her nose, over the nasal spine by the columella. You can see that the tip is the high point of her nose, and she has a more feminine angle between the lip and the nose. This is a 22-year-old female from the subcontinent in Asia. Here again, she felt that her nasal bridge was too high and that the tip was too full. These are before and after photographs following a closed rhinoplasty. You can see that her nasal hump and her thick tip have been addressed, but she has maintained her ethnicity and, to her family, still looks like the same person. This teenage Hispanic boy felt insecure because of the size of his nose. We frequently do rhinoplasty surgeries on males and females of this age if we feel that their nose is fully grown. This helps them with their self-confidence as they continue through high school. From the side view, you can see that his nasal hump has been removed and his tip refined. This truly improved his self-confidence and his performance at school. This 32-year-old female came to see me, telling me that her nose was way too large for her face. It was wide and bulbous at the tip. She felt that she looked like a plain Jane with this nose. In her after photo, she looks much more feminine and is very pleased with her appearance. The tip has been brought down. The dorsum has been dropped to a point slightly lower than her tip, and her overall appearance is much improved. This is another patient who ended up with a much nicer profile following a rhinoplasty, including a graft to augment her nasal tip. This was truly one of the more difficult rhinoplasties I have done. She'd had 3 prior rhinoplasties through the open approach and had an excessive amount of scar tissue. Her nose was deviated and still way too large for her face. A dozen years later, she still remains very, very pleased with her nasal appearance. All of the rhinoplasties I've shown you to this point have involved some form of nasal hump reduction. There are many patients who come in who need material added to their nose instead of removed. Dorsal grafts and implants can be performed using your own cartilage, whether it's from the nose, rib, or ear, silicone, or hyaluronic acid. I have used porous implants and irradiated cartilage grafts in the past, but no longer use those because the results were not good long term. In the most severely collapsed noses, a cartilage graft from a rib may be the most appropriate alternative. It is sturdy, firm, your own tissue, and should give the patient good long-term results. This older gentleman had had his nose broken multiple times as a boxer in his youth. It's amazing that he walked around for 40 years without this bothering him very much, but did come to see us to explore the possibilities of improving his nasal bridge. I could have done more to his tip, but he just was not interested and just wanted the dorsum repaired, which I did by harvesting a rib cartilage graft. You can see that the rib gave him a reasonable nasal profile, one that he should be able to take with him for the rest of his life. If enough can be harvested, my first choice for cartilage graft would be taking some cartilage from the nasal tip or the septum. The ear is a second most common source for cartilage grafts, and this cartilage can be removed through a tiny incision in front of the ear or on the back side of the ear. This 54-year-old lady had an over-resected nasal tip following a prior rhinoplasty. She had no issues with the nasal bridge or the width of her nose. I was able to build up the over-resected tip by inserting some cartilage which I harvested from her ear. This gave her a very pleasing result, and she was one of the happiest patients I've had for years. A depressed nasal dorsum can also be improved by inserting a silicone implant. These Volosian implants are inserted through an incision inside the mouth with a dissection up behind the columella and over the nasal dorsum without any intranasal incisions. This spreads the tension of the skin and lessens the chance of extrusion. This is a photograph of a 44-year-old male who had such a dorsal nasal implant with a very pleasing result many years later. Over the years, however, I think that I have removed more extruding nasal implants than I have inserted successful ones. Most of the ones that I have removed were inserted in Asia and were too large for the patient's nasal features, putting a lot of pressure on the skin of the nose. This is an example of an extruding implant, which soon thereafter was visible through the skin. This is another such example, how not to use silicone in a patient who'd had a dorsal implant inserted in Korea 8 years prior to these photographs. These implants have to be removed, the nose has to be allowed to heal, and, if possible, reconstructed a year later using cartilage grafts. And the last thing I will touch on is the so-called non-surgical rhinoplasty. This essentially entails injecting some hyaluronic acid, Restylane for example, into the nasal bridge. This lady had had a nose done before and felt that the area just above the nasal tip was too narrow. She was very pleased with the injection of a very small amount of Restylane in this area. And on the side shot, you can see that her profile has been improved by filling out the small depression just above the nasal tip. Sometimes the least invasive procedure gives the most dramatic result with the least amount of risks. So whether we are working on breasts, faces, tummies, or noses, our goal has to be a happy patient. Without a satisfied patient, we have failed in our attempt to improve their looks. Thank you for joining us. I hope you'll join us for our next event on body contouring in June.